Great, thank you so much. Okay, so I'm Jenna Atiee. I just finished an IR fellowship at the University of Georgia. I don't have any affiliation on here because I'm currently unemployed. So if any of you need kind of a crappy internist, let me know. So we're going to talk about the evaluation of cross-linked gelatin as a bulking agent for the management of urinary sphincter mechanism incompetence in female dogs with a minor detour. So based on our listserv and then Veery's and some stuff probably from ASVNU, there's been a lot of discussion and back and forth as far as the importance of urethral length. And so I went back and did some searching to see what was out there. And so this is a little bit of a detour, and I'm sorry, but we'll get back on track. But just based on the discussions, I think it's relevant to this audience and has to do with incontinence. So this is a paper from 1985, and Holt did this. And actually, there's some really, really great data in here. And so honestly, I read this and like a light bulb went off. I feel really, really dumb for sharing kind of the progression of my thought process here, and it's embarrassing how behind I was. But I read this, and what struck me was the concept of the sphincter muscle encircling the bladder neck is inaccurate. And in fact, the whole of the bladder neck and urethra represent a tube of resistance to outflow in urine. So I really like physics. And so, in fact, if I don't know if Shelley Baden's on, but she knows I did a whole discussion on flow dynamics and physics for a seminar because I'm really nerdy. So anyways, when I read this, I was like, oh, this makes so much sense. And so the data they presented in this paper was actually, I think, pretty amazing. So they looked at continent and incontinent, and they had a reasonable size number of dogs. So 42 continent dogs and 57 incontinent dogs. And what you can see, this is one of the charts that actually, so they looked at both body weight and the length of L2. And you can see in the continent dogs, and if anything, they were actually smaller dogs, so lower weight. I'm so sorry, my cat has a lot to say about this. And the incontinent dogs were larger, but then if you actually look at both their urethra and their position of the bladder, the continent dogs, so again, were smaller dogs on average, had a longer urethral length compared to the incontinent dogs, who are at 7.1 centimeters compared to 8.5. And then when they looked at the bladder neck, they saw that they compared that to the pelvic brim on radiographs. And you can see that on average, the continent dogs were 1.5 centimeters in front of or cranial to the brim of the pelvis compared to the incontinent dogs who were on average 1.3 centimeters behind it. And they found that there was a good correlation between urethral length, body weight, and L2 length. And then this is one of their graphs, which I just drew for visual appeal. I think lines are a little bit easier than a bunch of dots. And so this is totally made up. These lines only represent what is in my head and not what you should 100% take. But I think if I were to make a best fit line, the blue line would be the continent dogs and the green line would be the incontinent dogs. And this is looking at urethral length versus body weight. And if you were to look at these slopes, you can see that the dogs who were incontinent had a lower urethral length compared to an equivalent body weight. Additionally, they looked at these dogs, the position of the bladder neck, and interestingly, the continent dogs, 35 of them had intra-abdominal bladder necks as far as where it started, with 7 of them being intrapelvic, versus the incontinent dogs, they had only 3 of them who were intra-abdominal and 54 who were intrapelvic, which really struck me as, I guess that was more skewed than what I've clinically appreciated. So I don't know if it's differences in population or if I'm just not very observant, but I did find that pretty intriguing. And so good old Bill Nye, just love him. He says that everything happens for a reason, and that reason is physics. And so, nerd alert, if you think of the urethra as a simple tube where flow of urine is going to be dependent upon, a constant pi times the pressure, which is going to be the pressure that is developed from the bladder and abdominal pressure for urine flow, times the radius to the fourth power divided by a constant, and then viscosity, which is going to not change very much, essentially constant, and then and the length. And so the length of the tubing is going to directly affect the resistance of flow to urine. And so it makes sense if this was just a simple tube, that the longer the length, the more resistance you would have and impedance to flow. And so I don't know why it took me so long to actually think of this so simply, but it finally occurred to me, and it makes a lot of sense. So sorry if I'm the dumbest one here and everybody else that's so intuitive, but I thought it was cool. So we'll go back to bulking agents now and back to the paper. And thank you for your time for that little segue. So in the background, they discuss the USMI is, the most common cause of acquired incontinence in dogs, and that ovarian hysterectomy increases the prevalence of USMI with up to 20% of spayed dogs that are affected. Interestingly, looking at the number of dogs who have USMI, 90% of those dogs are spayed. The medical treatment has several limitations, including it's lifelong. It only is going to work for as long as you give the medications, so that it has an expense to the owners and inconvenient over time. Sorry, what was that? Oh, I thought somebody was commenting. Side effects. This is something that I think a lot of us as internists face, with Proin in particular, with animals with cardiovascular disease, high blood pressure, glomerulopathies. There are some animals that are refractory. And so looking back at some of the original data, which again is kind of older at this point in time, but Arnold reported, for PPA, a continence rate in 1989 of about 75%. And then additionally, a few years later, Vic reported that tachyphylaxis was observed pretty quickly on, and I think as low as starting at a week in some dogs. And so with chronic use, tachyphylaxis was actually fairly common. And so that might be something to consider as far as for some of these dogs, if they had an original improvement in clinical signs and then became somewhat refractory, it may be, a tachyphylactic versus just a physiologic phenomena. And then with, things like estrogen compounds such as DES, they tend to achieve confidence in somewhere around 2/3 of dogs that they're given to, with some side effects obviously reported. And I was curious, anecdotally, I think a lot of us say that they're synergistic. And so I was curious as far as what data was available to say that. And again, back in the 80s, Creed reported that the combination of both an estriol compound with PPA improved the functional length of the urethra. I couldn't access the full article and could only read the abstract, so I can't give any more data as far as exactly how that was determined. But I thought that was kind of interesting that the functional length increased, particularly in relation to what we just talked about. And so in their background, they discuss, different options for refractory cases. So colposuspension and urethropexy were some of the surgical procedures they mentioned, with approximately a 55% success rate alone for colposuspension, and with a combined approach, about 10 to 20% complication rate, and then yielding a 70% success rate. That varies a little bit based on different references, and so probably 55% is a reasonable number to report. A lot of different references were closer to 50%. They also discussed transobturator vaginal tapes with a success rate that they reported at 80%. And then they stated that half the dogs require additional medical treatment to restore continence. I am honestly unclear as to how they came up with this 80% number. I went back to their original references and pulled them directly. And so in one of them, there were the original paper that discussed this technique for dogs. There were 7 dogs total, and 6 out of 7 of them were continent within a very short time frame after doing the procedure. So 6 out of 7 is about 86%. And then one of their other references was the same group who looked at these dogs at 1 year, and they included a few more dogs, so 12, and 7 out of 12 of those dogs were completely continent, so with a rate of about 58%. So that's the data that I found directly from those papers, just to share. And then one method that they didn't discuss, which I'm a little bit surprised a reviewer didn't comment on, since I think it's pretty prevalent now, as we'll see in our survey, that was the artificial urethral sphincter. And so this is a little bit of a newer technique. I know we have a mixed audience here, including some vet students who had emailed me ahead of time. And so if you're not familiar with an artificial urethral sphincter as far as what the actual mechanism looks like, this would be the occlusion piece that goes around the urethra that's connected to this tubing, which then connects to a subcutaneous port, which you can inflate or deflate with sterile saline in order to obtain the amount of pressure around the urethra that's desired. And so, again, about 90% continence rate, so pretty high, with a high client satisfaction rate as well. And then 10% of these dogs tend to develop urethral obstruction. A lot of that may be secondary to scar tissue, and some do require device removal. It's an open abdominal procedure, so that's something to consider. And something else, having managed a reasonable number of these dogs at this point, I do think good client participation and good education for them is really important, because this is not what I always tell clients, it's not a quick fix, and it does require a client who is going to observe patients, particularly immediately after the procedure. It takes, I think, it's variable how long it takes to achieve the appropriate filling pressure, but it can absolutely take a couple of months of back and forth to get the sweet spot. And if other people have different experiences, please chime in. I'm sure you have much more experience than I do in this. And so then, the other method, which we're going to spend the bulk of the time, no pun intended, talking about, would be bulking agents. And so they have a relatively high continence rate, minimally invasive. This is a cystoscopic procedure, low complication rate, tend to be well tolerated. But the need for procedures is something that, depending on the agents, may need to be repeated relatively frequently, which increases the expense, number of anesthesias, and potentially may be a deterrent for clients. And so I sent out a really short survey just out of curiosity, and thank you so much to those who responded and gave your feedback. And so I asked for female dogs with refractory urinary incontinence, so those who have not achieved satisfactory urinary continence with appropriate medical therapy, what procedures are you offering? And so the majority of people are offering either a combination or alone, an artificial urethral sphincter or bulking agents. There's about a third of respondents who are still offering colposuspension and or other surgical interventions. And then I allowed free responses, and I had 2 comments on this. And so one person said that they are referring for bulking agents primarily, and then the other person said that they're primarily doing bulking agents, but if collagen fails, then they're offering a surgical intervention. And so I followed this with what bulking agents are you currently using and what duration of continence are you observing? And so 3 people responded collagen. This was a free response, and 8 people responded with regain. And I'm curious, my guess is the people who responded with collagen are using regain. But if there's a different agent that I wasn't able to find, please let me know. And then the duration of continence that people are reporting who are using these in practice is quite variable, as you can see. So I took all the responses and organized them from kind of least to most, with the last one having multiple different answers. And so I didn't know what to do with that, so I just went at the end. But you can see, some people are reporting something as little as 3 months on average to as much as over a year. And I'm going to assume that this is primarily with regain. And then, one respondent who has used, multiple bulking agents in the past makes me really jealous that we can't get microplastique anymore. But, regain getting an average about 6 months, cell phone less than 6 months, and macroplastique greater than 2 years, which we'll see as far as some of the other literature, what we could find. So thank you to Dr. Barges, who provided me with quite a bit of information through a document he sent me in advance. And then, so I pretty much stole a lot of his information and then added to it based on what I can find in some of the other literature. And so going back, the original papers looking at collagen, which is a bovine collagen, had a reasonable success rate in dogs with a duration of continence of about 12 to 16 months. And unfortunately, this was removed from the market for women because it was no longer approved. And so then it became unavailable to veterinarians. And so with the kind of a need in the market being recognized, Avalon created Regain, which was another bovine-derived collagen that created a kind of a scaffold, which we'll talk more about later. And initially, the papers that I found were estimating about 68% continence rates. When they were combined with medical therapy, that improved to about 83%. Then Lutman in 2019, so a pretty recent paper, compared a veterinary collagen, I believe it was specifically Regain, with this dextronomer / hyaluronic acid copolymer, and so we'll get there in a second. And this was a long-term follow-up paper, and they reported in this paper a continence rate of about 71%, so quite similar to what was reported previously, with a duration of about 4 years. So that was a pretty impressive duration of continence for the animals that were continent. There has been some issues as far as availability of Regain, particularly in Europe, and I'm not sure about other countries. And with the original data, they reported about a 15% mild adverse effect rate, dysuria, hematuria, et cetera, things that I would say most of us would consider quite mild. And the cost is quite reasonable. So it's about $400 for the syringe, which comes with the needle. And if you're getting 4 years, that seems like a bargain. Then there is macroplastique. This is still a human product on the market. It had in dogs a 91% continent rate of about 1 year. This was done by Barges and Callens. They looked at 22 dogs, and then at 2 years they had a 90% continent rate in those dogs. Unfortunately, I'm unaware of how to obtain this as a veterinarian. If any of you have a supplier through a dark alley somewhere and want to secretly message me, I would appreciate it. But otherwise, I think they are not selling to the veterinary market. When it was available, it's about $450 per syringe, and then you would have to pay for the injection needle. And then back to Lutman's paper in 2019, the dextronomer and HA copolymer, they reported a success rate for continence about 58% with a duration of continence of about 20 months. They didn't report any complications. I was unable to find a direct medical source for pricing on this. HA is cheap, so my hope would be it wouldn't be terribly expensive. So that might be something to consider in the future. And then lastly is cell foam. And cell foam is composed of a gelatin that is combined with transglutaminase, which we will discuss more in the very near future. In unpublished data, it had a continence rate of about 75%. And I said other info, maybe this is now vet foam. So looking at the old information from cell foam, this was produced by the same company that created vet foam. It has the same constituents, but it was sold in a liquid versus a reconstitutable powder. So I'm not sure if there was something with like stability or something else and they stopped producing this liquid and made this powder, but it seems to be the same thing other than the formation. And again, it's produced by the same company. I can't find any more information on cell foam. So anyways, and we'll talk more about price at the end, but vet foam, which is now the product that we're going to be talking about, is about 400 euro per syringe. And again, I can't find anything about cell foam. And so lastly, as far as the survey, I asked if people were not using a bulking agent, what was the rationale? And overwhelmingly, the response was availability of agents. And then, a large percentage of respondents, of 50%, also said the need to repeat procedure. A minority of respondents stated that the cost of the procedure for clients was an issue. My guess is that's probably related to the need to repeat it. There were a few people who said they were unfamiliar or uncomfortable with the technique. And then there was a very small minority, so 2 respondents that stated that they had great success with other techniques, and so they didn't use it. Nobody reported anything as far as adverse effects or complications as being a deterrent. Any questions or comments at this point? Okay, I'll move on. So vet foam is composed of gelatin, and it's specifically a cross-linked gelatin. And so gelatin is a protein produced by the denaturization of collagen, and it preserves most of its cellular binding sites. So ideal properties of any bulking agents would be you want it to be biocompatible, adhesive to the tissue, plastic, have low immunogenicity, and be a tissue scaffold, which is something that theoretically a cross-linked gelatin could do. It's a good substrate for the enzyme transglutaminase, and that's important because as you can see up here, so if you utilize transglutaminase with gelatin, it creates a stable cross-linking, and then that allows for an actual tissue scaffold within the body, and then that will allow the migration of surrounding cells and stimulate tissue growth and have the ability to kind of grow upon that. This was a paper that used horseradish, which I thought was mildly entertaining. So vet foam is a medical grade porcine gelatin that's cross-linked with transglutaminase, again, same constituents of cell foam, into this porous injectable scaffold. And so the objective of this paper was to evaluate the efficacy and safety of this novel bulking agent vet foam in the treatment of urinary incontinence due to USMI in female dogs. Hypothesis, wah wah. And so we will move on. So this was a prospective study involving 15 female dogs diagnosed with refractory USMI. Refractory wasn't actually defined fully, so I'm not sure what the medical history is of most of these dogs. Their inclusion criteria was dependent upon history and physical exam, which included a neurologic exam. 2 dogs also had a urodynamic study, and then all dogs had a CBC biochemistry panel, urinalysis, urine culture, abdominal ultrasound, and cystoscopy to evaluate them. And then They all had to either have a negative bacterial culture or they were treated for a UTI prior to the procedure. They excluded any animal who had current anatomical abnormalities, such as ectopic ureters, at the time of inclusion. They could have previously had ectopic ureters, for example, and had been treated, but they had to have that be resolved in order to be included. And so for the procedure, this was done in right lateral. They all had a cystoscopy performed. And then vet foam was reconstituted with, depending on from the beginning to the end of the study, there was a difference. So they had a variable volume that they used to reconstitute this 500 milligram powder. So somewhere between 1.6 and 2 mils. By the end of the study period, they standardized that to 1.8 mils. And so they injected 2 to 4 bulges, 1 to 2 mils of vet foam in each bulge into the submucosa of the proximal urethra, which was 1 to 3 centimeters caudal to the trigone. They did this circumferentially, which you can see in this image. Bulges were added to achieve at least an 80% decrease in the urethral lumen. And then they used one of 2 needles, so a 21 gauge Urotech or a 22 gauge bow needle, or bony needle that was, a flexible needle through the cystoscope. That has also now been standardized as far as their technique. And so after they injected in each bulge, the needle was left in place after the injection for about 60 seconds to allow that material to stabilize so that it wouldn't leak out. All dogs were treated with amoxicillin with clavulanic acid or a different antibiotic if culture results indicated to do so. And then they were discharged on the day of the procedure after voluntary urination was confirmed. So they assigned continence scores prior to the procedure within the first week, which would have been the first recheck, and then monthly for the follow-up period. And so the whole study period was 36 months. So depending on different dogs, the follow-up period may have been up to 36 months. The procedure was considered successful if a continence score was greater than or equal to 4 at the time of the first follow-up. And then during the duration of, the duration of continence was defined as the time during which that continence score was greater than or equal to 4. This came from their appendix. This is their continence scoring system. It's as you get higher, they're more continent. As you get lower, they're less continent. And something that I considered, and I recognize other papers use similar scoring systems, but dog, this number 4, which is their marker for success, dog urine soils where it has been sleeping up to 50% of the time, but does not dribble or have a wet perineum when awake. I have had an incontinent female dog, and I've had to live with that. I would say peeing in their bed 50% of the time would not be considered a success for me personally. Maybe I'm a terrible human being, I'm a bad dog owner, but I have a hard time with that being successful. Just my personal opinion. So their statistics were pretty simple. So Wilcoxon signed rank test was used to compare continence scores before and after the procedure. A p-value of 0.05 was used as far as stating what was statistically significant, and the effect size was calculating using a Cohen's d statistic. So 15 spayed female dogs with UMSI were enrolled. The breeds included were primarily large breed dogs. So 10 mixed breed dogs, 2 Labradors, a Dog de Bordeaux, a Doberman, and a Pit Bull were all enrolled. The median age for these dogs was 111 months. I think that's about 9-ish years. And 3 of the dogs were previously diagnosed and treated for ectopic ureters. Their median age was lower at about 36 months, 3 years. And the median body weight of these dogs was about 25.8 kilos. And so again, these were all primarily large breed dogs, which I think is pretty typical. So the median incontinence duration pre-procedure was 36 months, which is it's hard. That's hard to live with. And the median continence score before the first injection was 1.5, so leaking almost all the time. 22 procedures in total were performed during the study period. So 5 dogs underwent greater than 1 procedure. And so 10 dogs only had 1 procedure, and then they had 4 dogs that had 1 single procedure additionally, and then 1 dog that had 3 additional procedures, so a total of 4 procedures. And then repeated procedures were performed because of either unsatisfactory results, meaning they did not achieve a continence score of greater than or equal to 4 after the first procedure, and that was for 2 dogs. And then recurrence of incontinence was the other reason. So they had 3 dogs that had recurrence of incontinence at 4, 6, and 13 months. The mean procedure time was 30 minutes, which I think is pretty good. And satisfactory results, so again, a continence score of greater than or equal to 4 was achieved in 13 out of 15 dogs, so 87% after the first procedure. And again, that timeline where they measured that was in the first week. In dogs requiring greater than 1 procedure, 7 out of 7, they stated, so 100% had continence scores of greater than or equal to 4 after treatment. This is, I think, a little bit of a confusing line, at least for me as a reader. So this was 7 procedures and not 7 dogs, and 1 dog needed 4 procedures. And so, yes, this dog eventually achieved a continence score of greater than or equal to 4, but that was 4 procedures in. So his or her final continence score was 5 after each procedure, but it decreased at different time points. So at 3 months, 15 months, and 21 months after the original procedure, she had to be retreated in order to maintain continence. The median clinical continence score, was significantly different between pre and post procedure. Their effect size was 2.6, and so reviewing stats as far as what effect size is a large effect, anything greater than 0.8 would be considered a large effect. So for those of you who are like me and needed that refresher. And so most of these dogs increased to a continence score of 4 with a range of 1.5 to 5 within the first week of the procedure without any additional medical treatment. So in 5 dogs, medical treatment was added to maintain continence, and this was PPA plus minus DES for a mean duration of 4.1 months post-procedure. So two dogs had continence scores within 2 weeks of 3 and 1.5. So they had medical therapy added. 1 dog had this happen at 4 months. 2 dogs happened this at 4 months. Their continence scores were 2.5 and 2. And then 1 dog at 8 months with the continence score of 4 after the procedure. And then the mean continence duration for dogs undergoing this procedure was about 11 months. And that's something I think that is kind of a helpful number, albeit potentially an underestimated number depending on the duration of follow-up, which we'll talk about. And so when thinking about other bulking agents or the patient that you're going to recommend this for, I think understanding what's the average duration of therapy is pretty important as far as how many procedures do I expect this dog to need in its lifetime. And so at the writing of this manuscript, 3 dogs were still continent at the time, and so that was 21, 22, and 36 months post-procedure. 1 of these dogs only had 1 procedure, and then 2 dogs had medical treatment was added at 4 and 8 months after the procedure. So they were continent with 1 procedure plus medication. And then 2 of the 5 dogs receiving medical treatment remained continent despite remained incontinent despite the addition of medication, and so bulking reimplantation was repeated. All right, we're going to get through the results quickly here. Almost over. So 4 dogs died during the study period because of unrelated reasons. 1 dog had pulmonary neoplasia. 1 dog had hemoperitoneum and pulmonary metastasis secondary to a liver mass that happened 3 months after the procedure. 1 dog had actually multiple myeloma 11 months after, and 1 dog died 6 months after the procedure for an unknown cause. This was kind of a depressing slide, so I needed to add something cute and humorous. And so moving on to the discussion, any questions about the results? I know that was very data heavy. Okay. So, one of the major drawbacks of bulking agents, as demonstrated by the survey for a lot of us, is the need for repeating the procedure and the temporary effect. Theoretically, what the authors state was that, vet foam being a scaffold for fibroblasts replaces the matrix and produces this natural scaffold with a volumetric and functional effect of its own. And so over time, the body produces its own tissue kind of as a response to the scaffold that can increase the bulk and the resistance going through the urethra. So it has the potential to provide a long-lasting solution. Some of these dogs were still continent at the end of the study period, but this is, to a reminder, this is 3 dogs out of 15. And so I think it's important, and the authors do point out that there is a need for additional studies, longer follow-up, histopath would be helpful, and I think the jury is still out. So 2 dogs had continence scores of less than 4 after their first procedure. One of these dogs was the very first dog enrolled, and after the second procedure had a continence score of 5. So there was some consideration, maybe there was a learning curve involved, and perhaps that was why. The second dog had an ectopic ureter that was previously treated. She also had hydronephrosis and ended up with a nephrectomy, and so she had some anatomical differences, and so there was consideration given to perhaps, because of the scar tissue of when she had one of her ureters laser ablated and some changes within her urethra, that this dog was less amenable to bulking agent. That being said, they did have other dogs with ectopic ureters that were previously treated who did achieve continence scores of greater than or equal to 4. The mean continence duration may be underestimated because of the follow-up period. So depending on the dog, the duration of continence was highly variable, going from 0.5 to greater than 36 months. And again, the study period went up to 36 months, and so some of these dogs had a shorter follow-up than others. Side effects were quite minimal. So they had a single dog who had self-limiting signs. And then there was another dog that had a urethral diverticulum that was thought to be secondary to a previous injection. So it was in the same location as a previous injection. There was some discussion as to maybe this was secondary to delay of healing of the mucosa. And in humans, mucosal erosions are reported secondary to bulking agent implantation, and pseudodiverticulums are believed to occur as a sequela of a spontaneous pseudoabscess drainage into the urethral lumen after the bulking agent implants. So they did talk about the fact that this lesion did not look erosive in this dog, so a little bit unclear as to what that was. It wasn't biopsied, so who knows? So, as far as this paper specifically, limitations, sample size, 15 dogs. The follow-up period was 3 years, but that wasn't for all dogs. There were various dilutions with the saline as far as reconstituting the agent, which at the end they ended up stating that 1.8 mils was the appropriate dilution ratio. They did have 4 dogs die during the study, unrelated to bulking agents, presumably. It's too bad that histopath wasn't able to be obtained on their urethras. And then again, for me personally, having lived with a very incontinent dog, the characterization of success, I think, is something that I would have characterized differently. So I contacted the company as far as costs and how available it would be and how difficult it would be to obtain this. And so they are very responsive. And so a single unit cost is €395. So right now with euro to dollar conversions, that's about $467. For new customers, they are offering 3 units of vet foam free of charge. So you just pay for the shipping. And so they also stated that normally they give a 3-month guarantee, which means that if a patient becomes incontinent during the first 3 months after bulking agent implant, then they can get another unit of vet foam free of charge. The vet foam injection does require the bony needle, which is I guess produced by Coloplast. There are several places you can purchase those that I was able to find somebody else here who's may have a better source. I found it through several medical suppliers for $45, but all of them, they were out of stock. And then BioChange, the company that makes vet foam, will sell you one of these needles with your syringe. They'll sell it for €90, which right now, again, is about $106. So just FYI. So with that, I will happily take any questions or comments.
Jenna, that was great. Thanks so much. That was such a thorough review. One thing that I've done, and I'm curious to see how often others might have, is with and I'm using the Regain collagen from Avalon, but there are a number of dogs where I'll use 2 syringes worth of collagen to treat them, because after the first syringe, I might have given them a single ring, which I'm happy with, but their urethra is just enormous to begin with. And so I find that if I place a second ring of collagen, that a lot of those dogs will tend to do better. And it clearly just makes sense, having more resistance, hopefully more kind of long-term resistance that's there. And I think for us, certainly the cost of the collagen is not, it's not super expensive, it's not super cheap, but it's way more cost effective to do 2 syringes at one time rather than another anesthesia event and all the setup that goes with it. So I don't do that for everybody, but I don't hesitate to do it if I feel like I could potentially give the dog more continence. And I've never seen a dog become obstructed even after I put 2 syringes in. So I wasn't sure if any other people had experience with using kind of twice the dose and what their outcomes might be.
We've done that once, maybe twice, and for the same reason that you just do one and maybe there's more leakage than you want, or it doesn't close down completely. And I can't say that I feel like those animals have done better necessarily, but we've never really gone back through our cases to see what our outcomes are in any systematic way.
And lots of good questions and comments on the chat. Joe had asked, how much are you coapting? And personally, I try to coapt so that there is just complete obliteration of the urethral lumen. I like to try to get the bleb so that I don't see anything in the center. And then, yeah, and Julie had mentioned putting one at the neck and one in the middle third of the urethra. That's usually what I'll do. And I think that I do think that there are some cases, I imagine probably I inject the collagen and who knows, 15 minutes later if it just might leak out or something like that. I don't do the technique that they described here, where after injecting you leave the syringe needle in for a minute so that kind of take hold and not leak out. I make the bleb and then pull the needle out and then redirect. So maybe my technique could change as well too.
I'm, oh, sorry.
I'm curious how many people do this at the bladder neck, because we always start with our first ring beyond the bladder neck when you start to see some, you should start to see some closure of the urethra. So we don't really start at the bladder neck. So I'm curious how many people start there.
I would place one in the first. I usually don't do it right at the junction because I find that's just really hard, I think, to maintain visualization. And I like to do it within probably the first couple, like 1 to 2 centimeters or so of the urethra, so that I know it's solidly within the proximal urethra, but away from the junction, so I'm not going to get the collagen just to track up the bladder rather than in the urethra personally.
Okay, I was just curious.
So when I was looking up various, different agents and looking at macroplastique to see if I could find a way to obtain it, there is a video as far as how to appropriately apply it. And they have a tunneling technique that's described that is the approved method of doing it. And they explain that it improves the amount of tissue bulking based on being able to, get this in between the layers and less leakage. And so the needles that the macroplastique comes with has these little markers on it. So you come in at a 30 to 45 degree angle to one marker, and then you flatten out your scope really, and then you advance the needle into the next marker, so it creates a tunnel for the agent. And I was curious if anybody has specifically done that or something similar and found that reduced leakage, because I also have not personally, held the needle in for 60 seconds to avoid leakage. But I thought it was interesting, the tunneling technique that was described.
So I'm sorry, JD.
No, go ahead, Joe. I've been already talking too much. Go ahead.
No, well, first, I appreciated the conversations and the comments in the chat. And being old, I can remember way back using Polytough. So, I haven't really used Regain, but certainly with Conagen, I mean, you just had to inject. I remember Dennis Chu telling me when I first started doing it, he would say, you have to walk away thinking you've obstructed the dog if you're using collagen. And so then I got much more aggressive with it. So it sounds like we're going to probably start using Regain at some point. And that's the way we're going to have to approach it, because I think collagen is pretty malleable. But with the macroplastique, having done that study, which the interesting thing about macroplastique is it's a combination of things. It's a silicon-based product, and it has this sort of vegetable oil carrier with it that is absorbed, and so it's supposed to form in histologically, microscopically, it forms channels, almost like a sea sponge. And the idea is that it allows fibroblasts and stuff to grow into those chambers, into those channels. And so it's really thick. Collagen was not near as thick as this. And so that's part of the reason for the tunneling aspect of it. I still, when I've done bulking, have held the needle in, maybe not as long as 60 seconds, but enough to let at least some things set up. But I actually have been trying to get to the company to see which has been sold, if they will start selling it to veterinarians again. I was very happy with it. If it comes on the market, if anybody ever gets hold of it, one thing to know is the carrying agent, that vegetable oil liquid, thick viscous liquid that it's dissolved in, it looks almost like it's a colloid, so you can see the little speckles of the actual product in it, but then it's in this carrier, is that carrier is actually a histamine sensitizer in dogs. And when we were using it, we have a percentage of dogs that would, on recovery, start breaking out in hives. And we'd give them Benadryl, and they did fine. And then when we looked it up, it's something from like the 40s. You want to pre-treat them with Benadryl if you ever get macroplastique, or if you can get hold of it, just because some dogs will wake up with just these massive papule reaction.
I've used just once or twice the coaptite, which I don't think is still on the market, but that product used that similar kind of needle where it was just a smooth bevel, and the actual port that the product was being injected out of was a couple millimeters from the tip. So you would have to do that same tunneling technique as similar to the macroplastique. And that product actually turned into hydroxyapatite once it was, or a molecule very similar to hydroxyapatite once it polymerized. And it seemed like it had potential, but it is definitely not a product that was amenable to teaching. I remember trying to show residents how to do it, and once you would reconstitute it, you would have, I think, about 60 seconds to get the product injected, and then it would turn to bone in your syringe, which was a bummer when it cost like $650 for the syringe. So it was one of those experiences of, watch this, we'll talk about it later, but a bummer that trainees couldn't get a chance to practice because it was so expensive. But has anyone else tried that one before? I don't think it's on the market anymore, but that was another thing that was out there at the same time as like the microplastique.
Yeah, I tried it like twice and had the same problem. It solidifies so quickly that I just gave up. And in people, I don't know if it's still on the market either. I haven't looked. In women, there was a certain percentage that would have mucosal necrosis because of the hydroxyapatite setting up and causing pressure. So I don't know if that's a reason it went off the market, but I only tried it a couple times and gave up.
So a few comments that I made. This is Gilad, and first I have to admit that I'm one of the authors on this on these papers, so I've used this material quite a lot during the process, and so a few comments. First, cell foam and vet foam is the same thing. It's the same company. They just changed their name in the middle at some point for what I'm not sure what was the reason for that, but basically it's the same stuff. The reason why we kind of leave the needle inside for 60 minutes is because, as you had mentioned, we had some learning curve in the beginning. So to begin with, we tried to use the minimal dilution that we could, and the material was relatively thick. And then we increased the dilution, and it was much more liquid. But if we put the material in and immediately took the needle out, like I used to do with the collagen, sometimes it just would leak. And we didn't know if it's going to stop immediately or after 60 seconds or whatever, but it was leaking, and we're afraid that we're going to lose the material. And so this is why we said, let's keep the needle inside just to make the stuff stabilized a little bit. Finally, with the right dilution, I think that's not necessarily something that you need to do for 60 seconds, but if we do that today, we would still leave the needle for 10 to 20 seconds, back it out, see if there's any leakage, and if not, we just continue to the next bulge. So this material has some learning curve, and because you have to do the dilution on spot, and so you do the dilution, you mix the material with the saline, and then you do the injection. So you have to be accurate to get the right dilution. So there is some learning curve. It's not like the collagen that you just take the needle and inject. So it's a little bit different, but the advantage is that you do have 3 syringes, and you can do, as JD said, you can do more than 1 ring if you want to. You can do a spiral, you can do whatever you want. We do that, as you had mentioned, few centimeters or distally to the bladder neck, just because with previous experience, if you do it on the trigone area and the bulges kind of penetrate, or just at the right trigone, it may cause some pollakiuria and stranduria and stuff like that. So we go back 1 to 3 centimeters. At least I read in some place there is a theory at least that maybe with kind of stretching the muscle of the sphincter, you get a better response with PPA later on if you need to. I'm not sure if this is completely theoretical or someone had actually showed that in the past, but that is kind of my comment and experience with this material.
Well, thank you so much for commenting on that and your experiences with it. I thought it was it was a really interesting read, and I think a lot of us would love to learn, from experiences with this in the future.
I'm curious to know if anyone's had any issues with causing a urinary obstruction. We read the vet foam paper and we were considering starting to at least give it a try here at Oregon State, but one of my colleagues brought up that concern. So I just was curious about if anyone's ever experienced a urinary obstruction.
Yes, I can tell you yes. Not with collagen. Macroplastique, when I first started using it, again, if you get it, it sets up. And within the first 10 or 12 that I did, I had a couple dogs that were obstructed after the procedure. What we did was just place the Foley catheter overnight, and then they were fine. What I learned to do with macroplastique, at least, is I would do the coaptation, and then I would not pass the scope through the ring, but would fill the bladder up with sterile fluid, and then express the bladder by palpating through the abdomen, because I do them on their back, so I could palpate them through the ventral abdomen, and I could see the coapted site open up. I will tell you with cell foam, I did 3 dogs. They sent me some syringes. 2 dogs did really well. That lasted about 10 to 11 months. One dog, though, was a dog who had an occluder on, and I had injected collagen in some dogs with occluders and didn't have a problem. But unfortunately, this dog, I used cell foam, and the dog who was incontinent, even with the occluder, and we couldn't get incontinent with the occluder, ended up obstructing, and we had to go in and take the occluder off. Interestingly, that dog stayed continent for about 18 months without the occluder after we bulked her with the cell foam. So I don't know if it was a combination. It was probably a combination of things, but it worked really well in that dog, a little too well.
And I don't know if Julie has her microphone on, but she did I forget if it was the ASVNU or Veeries or maybe both, but a survey just asking people if they'd had that experience with collagen, and nobody had reported that they had. I think collagen tends to be a bit softer and fluffier, and you can pretty much chuck as much as you want in the urethra, and I get one who's become obstructed from that. I don't know if anybody else had one with collagen.
I've never personally seen it with collagen, whether it was collagen or at all. I mean, and again, you remember Dennis just saying you have to feel like you've obstructed them if you really want this to work, and so you just have to be gutsy.
So this is Larry Adams. I was working with a research product probably 25 years ago made out of SIS. And I did transiently obstruct one dog, and I didn't want to push the collagen out of the way, so literally threaded a little 5-French urinary catheter in the dog overnight. She was fine by the next day. So, and of course she belonged to one of our hospital nurses. So.
Did she do well for longer? I often wonder if we get to that point where we start tempting fate, if maybe it would give us better outcomes.
The SIS was a nice response initially, but it was reabsorbed way too fast. And the idea was maybe it would form more functional tissue, but it just turned out to be reabsorbed way too quick. And so that's why it never went very far. There's a crappy product from ACell out on the market, but I don't recommend it.
And I can tell you with the macroplastique, I did 20 some dogs for the study, but we did probably double that outside with dogs outside the study. So I obstructed, I think, 6 or 7 dogs, and those dogs, again, overnight with a Foley in and then removing it the next day, those dogs stayed continent for well over 2 years with one treatment. So it's kind of interesting. Like if you push them to the point of obstruction, they might actually do better longer. I don't know if that's true or not. It's a small number.
Yeah, it's an interesting concept, rather than thinking of it as just an outpatient procedure. If you put enough in that you have to leave them overnight in the hospital with a Foley, pull it the next morning and send them home, and if that gives you a better outcome, that might be more clients might be more excited about that type of longevity than if you don't have quite the same duration of effect. So interesting to think of. Well, Jenna, this was a great discussion. Thank you so much for leading everything today. I really appreciate it. I'll go ahead and stop the recording. And you just wanted to again say thanks to everybody. We do have another round session in 2 weeks. Dr. Lonk will be presenting on renal secondary hyperparathyroidism, which is great. And we will, before the next meeting, I'm going to actually cancel the go to training ID session so I can create a new one. So be on the lookout for emails from me. This way people you'll have to re-register, which I know is really annoying, but there are so many people that want to get into the rounds that are unable to because of the registration being full. And clearly we don't have all 200 people in the session today. So I'm gonna just cancel out the remaining sessions for the existing ID, create a new ID so that people can sign in and have less problems So just be on the lookout for that. You'll see some emails from me, as well as another plea to continue to sign up. We have another session that's scheduled for December, which is great, but we have a couple meetings that are still open until then. So please sign up if you're interested. Thanks so much for joining, and chat with you guys in 2 weeks. And thanks again, Jenna, great presentation.